So I'm going to start with the land acknowledgement. So the University of Alberta acknowledges that we are located on Treaty 6 territory and respects the history, languages, and culture of First Nation, Métis, Inuit, and all First People of Canada, whose presence continue to enrich our vibrant community. I'd like to also thank Paladin for their support of the ATI seminar series. It's my pleasure today to introduce our speaker, Dr. Emily Blumberg. Dr. Blumberg is a transplant infectious diseases specialist and the director of the Transplant Infectious Diseases Program and the ID Fellowship at the University of Pennsylvania. She's a deputy editor of the American Journal of Transplantation. A member of AST since 1999, she served as its president from 2019 to 2020. And is the current chair of the Public Policy Committee. She's a former chair of the Eunice Disease Transmission and Advisory Committee, former vice chair of the HHS Advisory Committee on Blood and Tissue Safety and Availability, and former member of the Gift of Life Philadelphia Medical Advisory Board, and current member of the Eunice MPSC. Dr. Blumberg's academic interests are focused on infectious disease complication in transplant recipient and candidates. She is especially interested in donor-derived infections and viral infections, including HIV, CMV, hepatitis C, and now, of course, COVID-19. Dr. Emily Blumberg's presentation title today would be, Can SARS-CoV-2 donors help resolve the donor shortage? Thank you, Dr. Blumberg.
Great. Thank you so much for that introduction and for the invitation to speak today. It's great to see you all virtually and would be nice in the future to even see everybody in person. So many thanks. Hopefully everybody can see my slides. These are my disclosures, none of which are actually relevant to this talk. It's been a very long 2 years. And transplant has really felt the impact of COVID-19 as so many other areas in medicine, so many people have as well. At the onset of the pandemic, we were really wondering what was the best way to handle transplantation. And it's pretty clear that the reaction was really one to decrease transplantation while we figured things out. Here in the United States, you can see that there was a notable decline in those early months of the pandemic, especially in live donor transplants, but also in deceased donor transplants. I looked at the data in Canada, and it really was quite similar. In those first couple of months, the number of transplants depicted by the red line on the left-hand side clearly declined dramatically, as even though the COVID-19 cases we learn now retrospectively were actually at a relatively low point. When we compare in Canada the number of transplants in 2020 compared to 2021 or 2019, it's also clear that the number of transplants, especially during those early months, declined. Why did this happen? Well, early on, it's hard to remember those days, but there were a lot of things going on that impacted our ability to conduct transplantation throughout the world, but certainly in North America. We were not prepared from a supply chain standpoint. There were tremendous deficits in our supply chain. There was a lot of competition for resources, including things like ICU beds, ventilators, the materials required to run tests, and even operating rooms, which had in our center at least been partially deployed to be patient rooms should they be needed. There were also some important transportation disruptions. With the holding of a number of commercial flights, it became clear that some of our organs, which were being transported on commercial flights, no longer had the same options they'd had before. And so that also impacted the ability to efficiently conduct transplantation. Being able to obtain consent and assent from families was also disrupted as hospitals became closed units and people were not allowed into them to see their family members, regardless of the cause of death. There were also a lot of unknowns, and people worried a lot about safety. Was it possible that these organs could be infected with COVID, and would that promote an unsafe environment? How did we know what the optimal testing was for active infection? If somebody had COVID, was the organ quality going to be acceptable? Again, a lot of unknowns. There was also a lot of concern about whether or not sending procurement teams out was safe, as they often went to places where the infection control standards may have been quite variable, and the availability of PPE where they were going might not have been sufficient to protect them. And so there was this sense that conducting transplant was risky, and perhaps there was more of a benefit to waiting to avoid these possibilities of post-transplant infection, including COVID acquired in the hospital, and the downside of administering immune suppression. But time passed, and we learned that the supply issue challenges could be resolved. And we learned a lot more about improving the safety of donation, especially when donors had a history of COVID-19. Plus, we were confronted with the reality of what it meant to reduce transplant volumes. Interestingly enough, in those early days, transplant volume reduction wasn't necessarily tied to the amount of COVID seen locally. As you can see here, the most dramatic reductions in transplant occurred in Japan, Argentina, and Chile, despite the fact that their COVID-19 rates were relatively low. The US also experienced a reduction, but nowhere near the degree that we'd seen elsewhere. And remarkably, that was in the face of having one of the higher rates of COVID-19 and one of the higher rates of deaths in the world. Here's where Canada stands, somewhere in an intermediate ground. Transplant had been reduced, perhaps at the same extent or a little bit more than in the US, but the COVID rates were certainly less, and deaths attributed to COVID were lower. What did this mean practically? Well, it turns out, and this is the different colors refer to the different organs. So yellow is kidney, green is liver, the blue teal is lung, and the pink is heart transplants. And what you can see is during this period of time, there was substantial reduction in volumes, which ultimately led to almost 50,000 years of lives lost throughout the world. And so reducing volumes had clearly come at a cost. But the world has changed, and one of the things that's become very clear, even as early as at the end of the first year of the pandemic, was COVID-19 outcomes in solid organ transplant and in non-transplant patients as well have definitely improved over time. Here on the left, you can see data from the University of Washington registry, which collected cases from throughout primarily North America, but there were some beyond North America as well. And you could see the mortality in the first part of 2020, as exhibited by that darker line, was actually substantially greater than that in the later part of the 2020. And this was largely due to our understanding of how better to manage these patients. And in fact, the greater use of things like antivirals that were more likely to be effective, such as remdesivir, and corticosteroids for those individuals who required oxygen. And so it became clear that we were now able to adapt our transplant practice. And despite what in the United States has been just extraordinary rates of COVID-19, we've managed to actually increase our transplant volumes initially to about where we were in 2019, but now even greater. And I'll show you some data in just a minute. In Canada, very similar things happened where you actually had that initial reduction, but then in later parts of 2020 going into 2021, the volumes had increased. And while they're not quite at the 2019 volumes in Canada, they certainly have exceeded that seen with the initial reduction in 2020. And in 2021 in the United States, it turns out we've now, despite the COVID pandemic and despite multiple surges during the year, there have been more lives saved than ever previously, with more than 40,000 transplants done in the US, with record numbers of kidney, heart, and liver transplants, and increasing numbers of deceased donors despite all of this. But despite these great successes, it's clear that in the US and in Canada, discrepancies between supply and demand still exist. And so, given the high death rates with COVID and people dying who've had incidental COVID, the issue came up whether donors with COVID-19 need necessarily be eliminated from the donor chain, but instead, could they be used to help address the donor shortage? So here we are in the United States, and you can see here the graph on the top in the left-hand side shows the new reported cases, and it's been quite a roller coaster, but we are just now coming off of one of the latest surges from Omicron. Consistent with that, we've seen these rebounding rates of both positive tests, hospitalizations, and certainly substantial deaths in the United States due to COVID-19. The actual rates of COVID, though, have really varied from community to community. And so the likelihood that we're going to have a donor in a particular community with COVID-19 varies tremendously from week to week and from location to location. This is Canadian data. And what you can see is it's pretty similar in terms of these surges up and down with the pandemic cases and with the variability in community spread. Deaths in Canada have also paralleled these surges, varying tremendously during the pandemic itself. Now, thinking about using donors with COVID-19 shouldn't really be that shocking to all of us, because in fact, there's a precedent that exists for the use of donors who've had respiratory viral infections. And in fact, there's a lot of information about using donors with diverse respiratory viruses, including influenza, RSV, parainfluenza, to name just a few. Now, in general, we've tried to avoid potentially involved organs, and so most of these donors have not been used for lung donation because of that. In addition, in cases where antivirals have been available, there has been a trend to treat the recipients in the post-transplant setting, and that's particularly been true for influenza. We've not, however, used any specific infection control precautions or monitoring in the recipients of these viruses. So I think there is some pre-existing comfort level for using donors with a history of respiratory viruses. So let's think a little bit about the pathogenesis of SARS-CoV-2 and what the potential would be for transmission. So we know SARS-CoV-2 is a respiratory virus, and transmission has been related to respiratory viral spread, both droplets and aerosols, which then land in the nose and mouth and potentially travel down to the lungs. There's a very brief period of viremia before the virus has potentially disseminated throughout the body, including to those organs we use most commonly in transplant: lungs, heart, liver, and kidneys. And so people have been able to actually isolate the virus there. But we never really actually started to think about transmission until about a year ago, when Dan Call reported the case from Michigan, where they actually had an individual with donor-derived COVID-19 infection. The case was very instructive because the donor had actually been tested with standard testing at that time, which was nucleic acid testing on a nasopharyngeal swab. That was done 2 days prior to donation, and the result was negative. And in fact, the donor did not have a history that suggested they had active COVID-19 infection. On day 3, the recipient became ill, and evaluation showed that they had COVID-19 pneumonia with a very low cycle threshold in the BAL, but a negative NP swab, suggesting that the donor may in fact have been a source of infection. By day 4, not just the recipient, the procuring surgeon was also sick. And so they ultimately went back and they took BAL that they had reserved from the actual donor and they were able to show that the BAL was positive with a very low cycle threshold. And I'm going to talk about cycle thresholds in a minute. But again, they were able to show that the recipient had not had any evidence of COVID-19 prior to donation. They were then able to do phylogenetic analysis and show that there was a homology between what was seen in the donor, the recipient, and the surgeon, proving conclusively that this was a case of donor-derived SARS-CoV-2 infection. Subsequently, there's been a very similar Canadian report where a donor was used, and again with an NP swab that was negative, and ultimately the donor would transmitted SARS-CoV-2 to a lung recipient. And when they went back retrospectively, they were able to find that at the time of implantation, a sample from the donor was actually, from donor lungs, was actually positive. Notably, despite treatment of this recipient, in both cases, unfortunately, these few cases of donor-derived lung transplant COVID-19 have all resulted in very poor outcomes and death. So after that initial experience, there was certainly a pause about what to do and to think about whether or not these donors could in fact be safely used. So there's been a stepwise approach, first looking at recovered donors, then donors with more remote infection, and then donors with recent infection. And I'm going to talk a little bit about what we know and sort of how we can approach these donors. So the first question people asked was, what's the risk of transmission from a deceased donor who's recovered from COVID-19 greater than 30 days prior to donation? And at this point, there have been multiple reports of both living and deceased donors, all of whom have recovered from infection. The organs donated have been quite varied, including lungs, liver, heart, and kidney. In each case, as the donation has been successful, there's been no evidence of transmission. And while most of these reports have to do with deceased donors, it's notable that there's actually been cases of live donation that have been equally successful. This is a report by Kute and colleagues from India, where they actually looked in the second 6 months of the COVID-19 pandemic, retrospectively, at centers that had actually performed transplants using donors who had recovered from COVID-19. In each case, the donor had 2 negative PCRs and no symptoms for at least 28 days. They then went on to look at both the donors and the recipients for outcomes. The mean donor age was 44, and all of these had had mild to moderate COVID that had been managed at home. In 71%, the cases had actually been asymptomatic. The recipients had a mean age of 39, and 87% had comorbidities, which isn't surprising given that they were requiring of kidney transplantation. 13% of them were actually ABO incompatible. And when they looked at the outcomes, they found there was 100% recipient survival, graft survival, and donor survival. There was a small incidence of acute cellular rejection, not necessarily more than they might otherwise have seen, and that all donors and recipients had normal creatinine a month and a half following donation. And so this was really quite a successful use of live donors who had a history of COVID-19 and fully recovered. But I think while we'd all feel comfortable with that, the situation becomes less clear when we talk about the donor who has active COVID-19. And by active, I mean detectable virus on nucleic acid testing of a sample from the donor. Now, there are a number of scenarios in which this can happen. The first of these is somebody who maybe has recent infection where you're actually able to time it, and it's probably less than 10 days. In some cases, there's been symptoms. In some cases, it's actually an incidental finding, but there's still this sense of relatively recent infection. In some cases, COVID-19 in that setting has been the cause of death. There are also individuals who've had infection that's gone on for longer than 10 days. Again, some of these cases may result in death due to complications of COVID-19, but in others, the testing is simply positive. It's been over 10 days and the donor has a different cause of death. The most difficult situation is the case where the timing is unknown. And in fact, the donor has very little history to help you, and the testing is a surprise. So let's go back and think a little bit about transmission potential from the standpoint of organs. So remember, after the initial infection, there's a very brief period of viremia, a matter of a couple of days, before the virus is transmitted to the variety of organs. But how long does it actually stay in those organs, and how long is it there in a way that actually results in transmissible virus? Well, we're starting to learn a little bit more about this. This is a really interesting preprint. I haven't seen it yet in PubMed, but it actually is available on the web by Cherto and colleagues. And these are researchers from the NIH. And what they did is they actually looked at autopsy tissues from individuals with COVID-19, where they were able to date the timing of the onset of infection. And they had about 40 individuals, but this is just a sample that's representative. To orient you to this chart, be aware that the darker the red is, the more likely there'd be a higher number of copies of RNA detectable. And this included detectable virus that clearly was viable and capable of reproducing. The darker the color in terms of whether it's black or gray or white, those were more likely to be negative. And the blues were very low viral copy numbers. So what we can see here is they actually surveyed a wide variety of tissues following infection. On the bottom of the chart, there's the number of days since infection. And so you can see the very bottom, the first set of 3 is less than 14 days, with the earliest being 4 days post-infection, 5 days, 13. The next group are 2 individuals, days 15 to 30. And then the last group is the individuals greater than or equal to 31 days. And what you can see here is clearly the further out in general you are from infection, the less likely you'll be able to find detectable virus in a variety of tissues. And in particular, that the viral load declines even earlier in some tissues. So let's look at the tissues that we think of for transplantation. The first I'm going to show you is liver. And you can see here in these liver specimens from autopsy, it was very unusual to find any significantly detectable virus that might be able to be transmitted as early as 4 days in this limited representative sample. If we look at kidneys, while there was a little bit of detectable virus potentially at day 5, in general, also the ability to recover detectable virus seems quite low in the kidney tissue as early as 4 days. Thoracic organs pose a slightly different situation, and you can see here that there was some detectable virus found in the thoracic organs, including myocardium and pericardium and aorta. But again, by the time you were past the 14-day mark, it was much less likely that you were going to see detectable virus in a situation where you could conceive of transmission. The big red flag, though, remains lung tissue, where you can see clearly up to even almost 3 weeks, there's the potential for viable transmissible virus. And so I think this gives us a basis for considering time as a major element to help us determine the safety of donation from a SARS-CoV-2 positive organ. So I want to pose something to you. We don't actually know what the infectious dose required for infection is. We do know with respiratory infection, the inoculum of exposure matters. And so, for example, people with milder infections with lower inocula are much less likely to transmit SARS-CoV-2 in general, although there is tremendous variability based on the variants, because it turns out that the binding of the virus really varies based on variants. And so Omicron was much more transmissible, although again, more so the more severe the infection was. This is all, however, based on a respiratory route, and we actually have no data on inoculum effect for the non-respiratory route. we also have no data on how that might vary based on variants themselves. And finally, we don't know anything about whether vaccination, which has proven to be not quite as effective at preventing transmission of things like Omicron, may be adequately effective to prevent transmission from viruses presented by a different route. So a lot we don't know. However, I think we still can think about using early versus late infection to help us try to think of this as a surrogate for viral load. So whenever possible, it's very helpful to start with a history if it's available. In general, it would be nice to know if they have a history of past infection, what the current risk is, including exposures, and when the onset of symptoms are, if that information is available and if they're asymptomatic. But unfortunately, with deceased donation, defining the timing can be quite difficult, especially in that setting. And so we have to look at other things. Now, over time, there's been a waxing and waning interest in trying to use chest imaging as a surrogate for this. But I think that even though radiographic abnormalities are common in mild to moderate infection, we know that organ donors commonly have abnormal chest imaging from a whole variety of issues, including aspiration, pulmonary edema, or non-SARS-CoV-2 infection. And so while this case here represents a SARS-CoV-2 infection, it would be very hard to distinguish it from other possible causes. And so I don't think we should rely on chest imaging to reliably define infection or even a stage of infection. So that brings us to the issue of laboratory testing. Now, initially, people thought a lot about whether antibody testing would give you a comfort zone, because we know that it can take some time to form IgG antibodies. And perhaps if somebody's antibody positive, this would suggest to you that the actual infection might be more remote. Unfortunately, sometimes antibody can be formed a little bit earlier infection, and I don't think it's a very good surrogate. We also know that antibody can wane with time, and so it may also provide some confounding. So we start to think more about the detection of the virus itself. And there have been two tests that have actually been looked at. The first is rapid antigen testing, like you can get in those home kits, or nucleic acid amplification testing, which can be performed on nasopharyngeal specimens, tracheal aspirates, or lower tract sampling, as you might find with a BAL. So how does this help us? Well, we know that the period of positivity for rapid antigen tests is pretty short. It starts typically with the onset of symptoms and usually is negative around a week or so after that. And so people have relied much more on PCR testing. Now, unfortunately, PCR presents its own issues, because we know that it can be positive both in the pre-symptomatic stage, which can be quite helpful, but the actual duration of shedding may vary with individuals. And so if you're just looking at this as a positive negative test, you can have people who remain positive on and off for a prolonged period of time. And in fact, we recently, saw this in just an individual who's not a transplant patient, who they, being evaluated for donation, who they'd been positive, then negative, then positive again. And so we know that the duration can be variable in this setting. So that brought us to the issue of whether or not we could use cycle threshold to determine donor eligibility. And Alberta has great virology, so you guys probably know this well, but I'll just say it in case there's anybody in the audience who has not heard from any of your really great virologists there. Cycle thresholds are the number of times the sample has to be, the virus has to be amplified to be detected. And so a lower number suggests a much higher amount of viable virus, and a higher number suggests that there's much less virus in the sample. And in fact, because these tests are looking at really fragments of RNA in this case, you may just be looking at residual RNA. So we know that the lower the cycle threshold is, the more likely you're going to have a positive culture. And in this particular study, what they showed that cycle thresholds that were in the low 20s or lower were much more likely to be associated with a cultivatable, transmissible virus. We also know that cycle threshold will actually vary based on time from onset. And so while very, very early in infection, you might have a high cycle threshold because the viral infection's just ramping up, typically lower cycle thresholds reflect earlier points of infection, and those cycle thresholds that are in our lab 30 or above are often just residual RNA, not reflective of active infection. So can this be a reliable indicator of infection? Well, unfortunately, not always. We know that the source of the sample is very important, and we can see here, for example, with these lung cases, that using nasopharyngeal and lower tract specimens can show a tremendous discrepancy, which does not reflect the ability to transmit the virus. We also know that how well you sample the specimen, is it diluted, how vigorous was the NP swab, will also make a difference. And there is, as with many things in virology, lab to lab variability. And so the platform and the lab itself may make a difference. And so my cycle threshold of 20 may not be your cycle threshold of 20. We also know that the detection of virus in a particular compartment, blood, respiratory tract, or even stool, may not reflect the ability to find infectious virus that's transmissible, because the cycle threshold is detecting the fragments of RNA, as I mentioned before, and so it's definitely not an absolute that finding it in one compartment is going to actually tell you what's going on elsewhere. We also know that respiratory viral shedding can extend for greater than 80 days, but that may not reflect viable virus, because in the normal host, viable virus has not really been isolated beyond the first 9 days of infection. And we have absolutely no guidance to correlate what's in a respiratory tract to the organ viral load. And so we have to think about things like that autopsy sampling to just give us an idea of where we might be. So based on that, what we're really looking at is an experiential expansion of using these donors. And we've now started to see more and more reports of using donors with positive nucleic acid tests, especially in the setting of kidneys, livers, and hearts. So far, with the exception of those lung transplant cases, there have been no apparent transmissions of any donors with SARS-CoV-2 positive NAT to recipients or to healthcare workers. And this experience, actually, in the next couple of weeks, we're going to see increased experience from UNOS, which is over 100 patients, and we're going to be seeing reports from a number of centers that have widely used these donors. For example, the Cleveland Clinic has used over 100 kidneys from donors who've had positive NAT tests, and there have been no transmissions. The outcomes so far, short-term, seem pretty good. There's been a death reported in a liver recipient, and there have been some cases of delayed graft function, but in general, we really are seeing pretty good results. And we've now started to see some reports even using donors who are much earlier in the infection process, including those who've had death due to COVID-19. So the question becomes, if we really can start to think about using these, is it going to expand our donor pool? How many donors are we going to miss if we exclude the NAT positives? So we don't really know that yet, although I'll tell you, we're working on a study from our own local OPO that's going to, I think, be informative. And I'm going to share just a tiny piece of our data from this. We do know that at this point, donor utilization of these donors is definitely lower and restricted to mostly to a few centers in the US, and I suspect in Canada as well. So what can we do? How should we approach these donors now? And what I'm going to talk about now are those donors who are NAT positive. Donors who were found to be NAT positive, who we know have a disease onset 21 to 90 days prior to donation, really seem to be quite safe. And based on sort of a UNOS guidance document, the transmission risk has been determined to be quite low. Donors who are NAT positive, but perhaps in that 10 to 21 day window post onset, who've had mild infection, probably are still okay as long as you're not considering them for lung donation, because while the transmission risk is officially unknown because it's not been looked at in quite an unbiased sample, we know that these donors are being used much more regularly, and so far there have been no donor-derived cases reported. The difficulty becomes in donors who are NAT positive, who we know had infection 90 days earlier. The transmission risk is unknown because it could reflect still ongoing positivity, but we know, and we learned painfully during the Omicron surge, is that having had SARS-CoV-2 with one variant did not prevent transmission and infection with different variants. And so in those cases, there's this sense that this could be a new infection and perhaps needs to be timed differently. And perhaps getting a cycle threshold here may help with this, but it may not have the full answer. Finally, there's the case that we see all too often, which is the NAT positive with infection timing unknown. In general, it's likely that the transmission risk, while unknown, is probably on the lower side, assuming that the donor is not dying from COVID-19. But this is a case where it's possible, but not guaranteed, that a cycle threshold may help you at least think about the timing of infection. At this point, there are still a number of unknowns. We actually don't know how the different variants may impact our safe use of these donors. The biggest experience that's been seen to date has been with donors with Delta, and we're now accruing the experience with Omicron related to the latest surges. And I suspect we'll learn a lot more now with BA.2 variants as well. We know that this sense of 90 days as a period for reinfection prevention was no longer applicable with Omicron. And so I think we're going to have to think a little bit differently about each variant as it comes along. The other thing we don't know is whether or not the long-term outcomes are going to be as good as the short-term ones, and whether that will vary based on the organ. And so I think it'll be really interesting to start to see 1 and 2 year outcomes as the time passes. We also don't know if we start to use more of these donors, will it have a big impact on the organ shortage? I think we're not using quite the number we might be using at this point. So my guess is it may, although certainly that's going to vary based on the pandemic epidemiology in the locality where the organs are being recovered. We also don't know a number of things in terms of the recipients themselves. There's been a lot of debate about patient selection. Do we want some level of immunity? Is it important? If we're saying the virus potentially is not transmissible, does it really matter if they have a history of COVID-19? And if so, did it matter which variant? Does it matter if they've been immunized? And at this point, do we actually know what constitutes full immunization? There's been a tremendous debate about the peri and post-transplant management as well. So far, most centers are not adjusting their immune suppression, but that's been a question of whether that should be. In the early cases, there was a lot more attention to COVID-19 specific management, but it's really not clear if it's necessary or available. Should we be giving monoclonals now that we have some options for antivirals? Is it worth doing that? We also don't actually know how to monitor for donor-derived infection, because remember, since these infections are being transmitted in a way potentially that's not a respiratory spread, we can't simply do NP swabs on our recipients and expect those to be yielding of a positive result if there was transmission. And so I think we're going to have to think about whether it's worth monitoring, what the best way is to do that. And finally, there's been tremendous debate about what kind of consent is needed to use these organs. Remember, we don't use consents when we think about special consents for other respiratory viruses. We've been consenting our patients a little bit differently with these organs, but is that necessary? I think time will tell. We also have a few institutional issues that really need to be considered. In particular, there's this sense of making sure the procurement is a safe experience. And so in our center, we've mandated healthcare worker vaccination, but it's possible that some places may not. And then you'd have to think about whether or not you really want your procurement team that's unvaccinated obtaining these organs. We don't isolate our recipients from these organs because we're not really concerned about transmission, given the fact that they're not developing respiratory infection. I think it's probably not going to be necessary, but it's something that's never been addressed directly. And I think the only way we're really going to learn about this is to really collate the data in a much greater way, rather than have a lot of single center studies where the management is so variable. This is what we're doing in our center here. In patients, donors who've had mild to moderate COVID, where the cause of death is not COVID, we have been considering them regardless of the timing of illness. Although donors who are less than 5 days from onset of illness, we really are only using those in the case of dire need and for fully vaccinated recipients. For those in the 5 to 10 day window, we're actually considering them for people who are fully vaccinated and generally speaking a little bit sick or higher priority, either due to illness or higher PRA. For donors greater than 10 days, where their illness was mild to moderate and the cause of death wasn't COVID, we consider those for any recipient, regardless of vaccination status. If you don't, if you have a donor who's died related to severe COVID, we have not been using those organs. Whether or not that can happen, we know that there have been now a couple of reports of donors with whose death is related to COVID who have been used, but I think we need a little more information about that, if for no other reason than for organ quality. In those cases where this is an unknown timing and the donor is asymptomatic and the cause of death is not COVID, we sometimes look for cycle threshold as just a window into when the infection may have occurred. And certainly for those individuals with higher cycle thresholds, we will use those widely. If the cycle threshold isn't known or less than 30, we think about preferentially giving them to the higher need fully vaccinated recipients, although we're not sure whether that level of precaution is needed. You know, unfortunately in our center, we have plenty of the people who are higher need fully vaccinated, so it hasn't really come down to thinking about it a different way. For us, the absolute contraindications remain severe COVID-19 or COVID-19 related thrombotic events. The relative contraindication is the immunosuppressed donor with COVID-19 because we worry that they may be actually shedding viable virus for longer periods. And we recommend that the ID teams be involved in the decision-making when these cases fall out of the standard. I'd like to end with one more sort of window into a way that COVID-19 may have added to our donor pool, although certainly in very tiny numbers, but just something that I bring up because Canada has used some of the adenovirus vector vaccines to a slightly higher extent than in the US, although actually not as much as I realize. So in Canada, you're very well vaccinated. 83% of the population is fully vaccinated, which compares favorably with the rest of the world and with the United States for sure. Less than 10% had received adenovirus vector vaccines, although I think you had access to AstraZeneca early in the pandemic. The adenovirus vector vaccines have been associated with this unusual syndrome of vaccine-induced thrombosis and thrombocytopenia. It's quite rare, but it appears to be a unique mechanism that probably involves autoantibodies to platelet factor 4, which leads to some antibody-dependent platelet activation, although other mechanisms have also been postulated, although this platelet factor 4 seems to be important. There have actually been individuals who have died related to this complication. And in Europe, there's actually been significant enough occurrence of this that it's been looked at as another possible pool for donors. And so there have been some limited use of this with variable results. In some of the cases actually did result in early major thrombosis or clinically significant bleeding. And there was this sense that it may be either pre-existing hemostatic or endothelial dysfunction in the allograft or some transmission of these pathogenic lymphocytes that produced anti-PF4. But there have been some guidelines for using these donors, in particular to avoid donation from these donors if there's severe DIC, and that the organs perhaps should be evaluated for the presence of thrombi and discarded if extensive. And recipients should be monitored with serial monitoring for thrombotic and hemorrhagic events, hemostasis, and anti-PF4 antibodies. And so not a very common occurrence, may never come up, but it is something that people have started to think about as another possibility. And I think we are going to probably see a little more adenovirus vector vaccine use because there's been so much interest in heterologous boosting. So even though you're largely mRNA in Canada, it may come up in the future. So in conclusion, I'd like to think that organ donation may be a positive in the midst of what's been a really challenging time for all of us. And while we certainly are not looking for more people to die with COVID-19 or from COVID-19, it's becoming increasingly clear that we can now start to consider some of these donors in the setting of organ transplantation, bringing some level of positivity to what's otherwise been an unbelievable tragedy that's affected our world in the past 2 years. And so with that, I'd like to be happy to take any questions. And thanks very much for this opportunity to share some thoughts with you about this today.
Blumberg, for this amazing talk. I just wanted to ask you about multivisceral and the safety of taking multivisceral from a donor that's SARS-CoV-2 positive with the risk of shedding in the small intestine, and if you've done that in your center.
Well, we're not a small bowel center, so the good news is it's never come up for us, but there's actually not been reports. And I think the reason is exactly what you said, which is, it's very clear that the virus is shed in feces for a very long period of time. And in fact, we're using throughout the US wastewater sampling as a way to figure out where the hot spots are in the United States. And so I am unaware of anybody who's using donors who are NAT positive for anything involving intestinal transplants. Now, SARS-CoV-2 recovered, I think, would be reasonable. There's no sort of standard screening in the United States or anywhere else that I know of stool samples for SARS-CoV-2 in the donor setting. And I suspect many OPOs would be reluctant to get into that process. But I think people feel that this is complicated enough, and so they haven't done it. And the centers that I know of that are doing small bowel in the US have not done this yet. So, but I think it's exactly for what you're, the concerns you have.
Dr. Laurie West.
Emily, that was a wonderful talk. Thank you so much. That's really so informative. And thank you for going to the trouble of seeking out the Canadian specific aspects of it. That's really helpful. I might have been predicted to ask this question, I guess, but you mentioned that there were ABO incompatible donations, which were perhaps a little bit surprisingly higher, maybe. I can't remember exactly what you said, but given the reported association between ABO blood groups and susceptibility to SARS-CoV-2, do you have any thoughts on that? Can you share anything about that aspect with us?
I think it's a great question, and I have no answers to it. I was actually surprised the ABO incompatible donation was in India from their live donor pool, and that's the biggest report I've seen of it. And they actually were using SARS-CoV-2 recovered donors. So these were not active settings. But I think that so far our experience with this really hasn't gotten into those issues. But I think that's why we need things like a registry for this, because those are the questions that I don't think any single center could answer effectively. But it's a really good question. If you start to look at ABO incompatible, can you tease out the virologic aspects from the rest of this, because I think one of the other things we don't know is long-term, whether there are going to be different issues we see. The short-term results seem great, but the long-term ones, we don't know. And there is a lot of complexity, especially when you start to think about, incompatible transplants, changing in sort of what you might do for your preconditioning or for your post-transplant immunosuppression management. We know that some of the agents that we might preferentially use may pose people, to put them at higher risk of infection. Certainly when you start to talk lymphocyte depletion, if you start to talk about the use of things like Rituxan, you're really putting people at tremendous risk for bad outcomes from SARS-CoV-2 and inability to respond well to vaccination. And so it's a really complicated question that I have absolutely no idea what the answer is going to be, but I think is really worth looking into with this larger registry type information.
I mean, it's so interesting because if you have, the blood group O recipients are reported to be less susceptible than blood group A recipients, who are reported to be more susceptible. But if you have an A to O transplant, that could be really interesting. And we've started to do some work that shows co-expression of the ACE2 receptor with A glycans, in lung epithelium and endothelium. And, so it may be, well, in heart as well. So it may be a question. I hadn't even thought about it until you brought it up, but you're right. It probably takes a registry to kind of look at that, because the numbers will never be very high, will they?
Yeah. I think the other thing to look at with that, which will be very interesting, is we know that COVID-19 has some risk of increased thrombosis.
Mhm.
And that might be very interesting too, because blood groups have different thrombotic risks, and whether that will be further accentuated in that sort of setting would be an interesting thing to look at also. I have no idea what the answers for that will be, but I do think it raises some very interesting and challenging questions, which unfortunately, I think we're going to have enough ongoing experience with COVID-19. We might actually be able to answer some of them.
Yeah, true enough. Thanks again for your talk, Emily. That was wonderful.
Anne, do you want to ask your question?
Oh, yeah, thank you so much. That was a great talk. My question is, you mentioned living donors sort of earlier in your talk, and then I think a lot of the data, unless I missed it, were more from deceased donor setting. But I think it's a really good question for living donation too, because, obviously you can reschedule in the case of living donation, but it's so disruptive to both the donor, who, may have a job and other things, as well as the recipient. So how is that generally being handled now? Like, I assume they're still screening for donors at most centers pre-transplant, but are we always canceling them if there's an asymptomatic positive in the living donor, or what are people doing?
So I can tell you what we're doing, and we have just revised this because the issues that you expressed about the complexity of scheduling these folks and, having it happen and be consistent with their lives as well is important. And we also worry a little bit because in some cases, but not all, our living donors are living with our recipients. And so we're considering both the potential for transmission or safety of doing general surgery on somebody with active COVID, and then taking somebody who may still be a little sick and putting them in with a fresh transplant. So there's a lot of complexity. We used to be very draconian in our approach to this and say everybody who's going to be a live donor had to isolate, quarantine for 2 weeks. They got tested at the beginning. They got tested before they donated. And then we said, if you're traveling, you got to do all the travel before, and it was really complicated, and people were saying this is too much. And we weren't sure it was necessary. And so what we do now is we ask our living donors to be careful for the week going into it. They all have to be RO, or you still have to be tested before you can undergo transplant and before you can donate. So they're all tested 24 to 48 hours prior to donation. And if they are positive then, and we did not have a history of COVID, then we cancel the case. If we find that they're positive, then what we've been saying is if they're asymptomatic, we wait 10 days and we proceed. If they're symptomatic, they have to both have passed at least 10 days and all of their symptoms have to resolve. So that's how we've approached it. I don't know if that's the right answer or not, but we do worry a little bit about taking somebody who's like potentially actively infected and giving them general anesthesia. It's just, you know, there early on in the pandemic, there was a lot of concern about doing general surgery in terms of outcomes for people with active infection. And whether, you know, all of this, you know, things are a little different now because we have antivirals, which could potentially make a difference. Although you probably wouldn't want to give a donor nirmatrelvir ritonavir, because the ritonavir will then induce the tacrolimus, and the, you know, may still be around in whatever organ you're giving, especially if you're giving a liver, you know. So, but yeah, I think we've become much more forgiving of the positive test than we used to be, but we still want 10 days because we just, both for the safety of the donor, but also just to limit the risk to the recipient.
Oh, thank you so much. It's not easy, is it?
I don't think any of this is easy. And the fact that it changes every couple of weeks in terms of what our knowledge is like, makes it even harder.
There's one question early from your talk in the chat. Was there an increase in the transplant that partly related to the opioid tragedy in either Canada or the US?
Was there any
increase in transplant? The increase that was seen, was it related to the opioid tragedy?
I don't know the answer to that. I don't know. I mean, I think that people, you know, a lot of what we've learned sort of has been learned after the fact. And so I'm not really sure if it's, you know, how it has related timing wise. I don't actually know the answer to that. I don't think so, but I don't know. I don't actually know.
I think we can take one last question. Ali Mherji.
Great, thanks. Thanks for the lovely talk. I was just curious at your center what you do for your lung transplant cases. Do you have a certain cutoff? You showed some data that there was viral, you're still picking up virus in the respiratory tract at 230 days. And so I don't know, is there sort of a time where you say that you can accept a donor for lungs?
We don't use these for lungs. We just don't. You know, it's interesting because we unfortunately have a fair bit of experience in lung transplantation for donors, for people who've had COVID-19, and we just are very cautious with this. I mean, I suspect that if we had better antivirals, that we would be more relaxed about using positive donors. You know, at least those who were like 30 days out, but anybody who tests positive, we just haven't been using them for lungs. We've used them for other organs, but we're just not quite comfortable. It seems like we don't have a necessarily guaranteed way to rescue. Yeah. You know, if you look now, for example, at the monoclonals for BA2, the bebtelovimab is not that great. We don't want to give them the Paxlovid. With molnupiravir, I saw some data actually recently that hopefully will get published that shows it's better than we thought it was going to be, because originally the response rates looked awful. And then remdesivir is, I would say, mediocre. So it's not like we have like a great antiviral for rescue. So right now, I think we're not doing it. I don't know if other centers are being a little more aggressive with their lungs. I don't know. You guys being more aggressive?
No, that's our practice as well. And we've stayed away from it, but I was just curious if there's a timeline. But I agree, I think with the risk, that's sort of the way to go.
Yeah. I mean, this has been a really challenging, difficult situation to try to figure out what the right thing is to do, you know. And I guess we're just learning as we go.
That's great. Thank you.
Thank you again for a great talk today. We'll just finish by introducing our next week's speaker. So Dr. Matthew Weiss will be presenting Organ Donation and Transplantation, Legal and Ethical Foundation of an Effective System.
Thanks very much.
Thank you.
For your attention.